we do have a forum, just who's in the room, so. All right, so first thing is, if you haven't taken a look yet, the minutes, the approval of the minutes from the November 18th meeting. Any concerns or changes, anything, errors that anyone found in there? If not, I'll take a motion in a second to accept them.
I'll make a motion.
Dr. Lynch?
I'll second it.
Dr. Clemency? So moved. All right. Moving on then to the CMAC SEMSCO report. Dr. Bart is not here, or maybe he's trying to call in, so I will kind of run through the CMAC meeting on December 8th. There were some discussions over the hemorrhage control protocols about placement of tourniquets, where they should be placed, the 2 to 3 inches above the wound versus up high in height, and more in line with the other standards across the country, TCC teachings and things like that. And that was the consensus, is that they should be placed high and tight. Those protocols should be coming out in the near future. There was also some discussion about 12-lead acquisition for basic providers, and that's been something that's been discussed at the CMAC for a long time. Not to make it mandatory, because that's a kind of big lift and a big cost expense for a lot of our BLS providers across the country, or across the state, excuse me. But I think that everyone realizes that a BLS provider can put stickers on a patient and press a button and acquire and transmit that EKG to the hospital for medical control, and it does change where we go, our destination for STEMIs and things like that. So the Bureau of EMS will be coming out with a policy that will allow 12-lead acquisition and transmission by basics, and that will be an optional skill at the BLS level. I think everyone's aware of the EpiPen check and inject pilot program. If people aren't aware of it, we can get you the information, but it is for basic providers to pull up and draw and inject IM epinephrine as opposed to using EpiPens, which saves a lot of money per ambulance. And that is ongoing. A lot of people in the area, a lot of our agencies have already gotten on board with that. Other than that, there were some other discussions about transfusion reaction or transfusion protocols, and that comes up later in the agenda, so I'm going to save that discussion for then. And other than that, I don't think there were any other big pressing issues, unless anyone else was at that meeting has anything they want to bring up. Dr. Taggins.
There was a tag form for discussion and investigation of the community paramedic.
Yes, there's been a tag that's been looking at that and discussing it. They presented stuff to the legislature, and it got, I think, turned down, and is ongoing trying to get that approved to change some of the Article 30 language and to allow community paramedicine to exist in the state. So that's ongoing. It's been ongoing for some time. That's okay. Go ahead.
Okay. Yeah, when the protocols were reviewed for the tourniquets, I just noticed this the other day. Is there any tourniquets are not listed like the CFR, EMR, transit protocol? I saw.
So yes.
Do you want to?
All right.
Hi, Rich Allen here.
Hi, Rich. Who else is on the line?
Good, Roger.
Anyone else on the line? Ron?
I'm texting him. He said they got cut off, so I told him I'd let him know.
All right. It will be. We just got the meeting started. We were just talking about some updates from the state. There was discussion about the new hemorrhage control policy. It will be a change in the hemorrhage control policy. It will be the BLS and the BLS protocols there, so it will apply to CFRs and EMTs.
It does?
Yeah. That's how the protocols are written right now.
Because I was looking at something online, there was like a separate CFR.
It's the state's changing the hemorrhage control policy, which will allow for tourniquets and hemostatic wound packing, and that was discussed at the last CMAC. And the policy hasn't actually come out from the state, but will be coming out very shortly.
Okay, thank you.
All right. All right. Now that we've got everybody on the line, and that moving on, we're going to start by going to the next item, which is going to be the Trauma Advisory Committee. Beth is not here. I don't know if Linda.
There's really no update.
Okay.
We're still looking at destination and transfer times in the region for RPI.
Very good. Next then, so there's really no update from the Trauma Advisory Committee, if you guys didn't hear that on the phone. Next up is the Nurse Advisory Committee. Chris?
Nothing from Chris.
Okay. Nothing
Just
from
right,
them?
real quick.
Yes.
In the minutes from the last meeting,
Yep.
we had left the issue of naloxone naloxone administration sign-offs.
Mhm.
I think we were gonna talk with the senior.
Yeah, so we had that discussion. The question was at the last meeting, we talked about signing off naloxone reversals and the legalities of that, and we discussed it actually on the ASAP conference call also, and then did discuss it kind of with a collaborative group there. The discussion is, I guess there's really no way that we can force those people to go to the hospital. We talked about that. Legally, they can't arrest them or anything like that either. But we should encourage them and try to push them to going to the hospital. If they absolutely refuse, then what's already in our REMAC protocol policy says that they do have to call for medical control.
The police can 2209.
They get 2209?
If they're willing to.
All right.
I mean,
We
there's-
can't make them, yeah.
Right, if we can request the police evaluate patients for 2209 status.
Do we think, I guess Josh, since you're bringing it up, do you think that there's something else that needs to be done specifically? Because the protocol already says if they're under the influence of drugs or alcohol, that you have to call medical control to sign them off. Do we
I
need
think that
something
it's
more
one-
than that? Because I think that's
I
exactly what
don't think so. I think that the discussion stemmed around the fact that we were hoping to get at least a consistent response out of the EDs when the people call for medical direction.
Meaning that we want the physicians, the medical control physicians to be giving the same response and the same answer? Is that-
Or at least approaching it from a similar direction.
And what do we want that response to be?
I think what you just summarized.
Okay. That they have to call medical control, but, and try to encourage them. And if we absolutely feel it's necessary, then encourage the police to 2209, is that what you're saying?
That's the appropriate.
That's what I would tell them.
So, right, I mean, so the science behind it, right, is there's a lot of research that was put out 10 or more years ago that said, if you get Narcan in the field, you're safe to be discharged. And that's the studies that people point to. The problem is, that was when heroin was pure on the streets. So all those studies that primarily come out of California are really not valid anymore, because even if you think you're buying pure heroin, you're not. Right? No one knows what they're taking. So I think that old data that people point to just isn't valid anymore when somebody's laced with fentanyl and everything else.
And I think that we are seeing a lot of still Narcan given for methadone, hydrocodone, and some of the pills too, which I think then obviously affects the duration and that. So I would agree that probably is not, those studies are not applicable, but I don't think we need to do anything else for this body unless anyone else disagrees. All right, moving on, we're going to go to the program agency reports, and we will start with Lake Plains. This is Donna Scott. Sit right over on the side.
Just have a few trainings that we've given. We have quite a lot of different opioid overdose classes, a couple of approvals for blood country, nasal Narcan and pads. We're continuing doing the nasal Narcan classes. We're starting to get reports from Niagara Falls Fire Department for overdoses. We're going to try to compile that, give it to you guys for next meeting. But they're averaging about 10 a month throughout the city, and the average age right now is about 36. And then what I got to put on the report was there is a certified instructor update at Niagara University at the end of the month, Saturday, January 30th from 8 to 4. And the contact information is on the website and also ours. And that's about it for Lake Plains.
All right, thank you. Moving on, STEMS, Donna?
All right, so we've had quite a bit going on. We attended all our county meetings. But for trainings, we pushed out the spinal motion restriction presentation, and we also did a distance learning with Jones in All-Star and Only in General, which worked out really well. We had people at each place so they could do the practicing of it, and got really good feedback on that. They really liked the video. They liked the consistent message, so that's something we could continue to do. I think that's a great idea. Again, we've been doing the Narcan programs. There was a stroke presentation at WCA that Dr. Falk, one of our medical directors, attended, and he spoke to the EMS providers there. We attended State Medical Council. We had an in-service with our hyperbaric chamber. And we have quite a few trainings coming up. We have a burn management presentation coming up that will be live at Olean and distance learn to all starring Jones, and that's totally full. So Beth's going to have her hands full with that one. We're doing an ePCR presentation. Mike Taylor from the state is coming down. That will also be distance learned. We are having our pre-screening skill exam on February 1st and 2nd. We are doing our CLI course on Saturday. We are also talking about doing an update on day 1. So kind of combining them, killing 2 birds with 1 stone. That was Ron Hansen's idea, so we're going to see if we can get away with that. And we're having a cardiology class on February 23rd because it's Heart Month.
All right. And then next, moving on, OBC, Scott.
Report's been distributed. We have our conference. It's coming up on Friday, April 15th and Saturday, April 16th. So that'll be a Friday night and an all-day Saturday. Just feedback from prior year participants that they don't want to have their entire weekend occupied by conference. So if we could do it as a day and a half, that's why we've switched that up a little bit from previous years. The WREMAC Credential CME program, we've had a number of site visits that have been completed throughout 2015. There were 31 services that were visited by Mike Krupski. I can never say the last name. Poor guy. Mike Krupski, who is one of our staff members who goes out, does the site visits, and provides follow-up reports to the services in terms of their compliance with the WREMAC Credential and CME policy. The feedback overall, and I've shared this previously, has been very positive, encouraging from really most of the services. I would never say everyone, but it's very close to that. They've appreciated the extra set of eyes coming in to review the documentation to ensure that they're doing it appropriately. And that's really been our experience through all of this, is that services want to be compliant. They just want to know that what they're doing is the right thing, and they want feedback in terms of how they can improve. So that's good. Within the report, and I won't read off the numbers, this is a revision from the numbers I shared with you in the November meeting in terms of the number of providers that are in the Wyoming Erie region, at what levels, and then also we have retention data in there for the providers who were registered with us from January 1st through December of 2015, and that is those who did not renew since January of during 2015 rather. We do have a preceptor training course coming up for the WREMAC scheduled for February 27th at LVAC from 9 a.m. till noon. Online registration is available for that. We also have an EMS officer training course, which we always have in excess of 100 people who attend the program. That's going to be on Saturday, February 6th at the Jameson Road Fire Company from 9 till 2. Online registration is also available. And what we also tell people with that program is that it is not necessary for you to be an EMS officer to take the class. If you think that you're going to be the EMS officer in 3 months when the current guy quits, then you should take the class. Or if you ever have an interest in becoming an officer in the future, you should take the program. That way you're ready for the position when it becomes available.
The leader passcode has already been entered. You will be joined as a participant.
Yes.
After the tone, please state your name, followed by the pound sign.
WREMAC.
There are 10 parties in conference, including you.
Scott, could you just mute that?
Got it, you're there.
I'll just put it in the toilet.
Can they hear us?
Well, all the dogs in the neighborhood are down there freaking out.
All right, sorry for you guys on the phone. We had some issues with the conference call line. You guys can all still hear us on the line?
Yeah.
All right.
Yeah, it's a little choppy, but we can hear it.
All right. Continue, Scott, I'm sorry.
We've had a number of services enroll in the check and inject program. We have an EPCR request for the village of Springville, which will be operated by Mercy EMS. And the RTAC meeting
February 3rd.
is scheduled, I just want to make sure it's confirmed,
That's right.
for February 3rd at 1:30 at the Erie County Medical Center, and the invitation for that has been set out. The EMS partnership meeting will be held at South Buffalo Mercy at 6 p.m. on Monday, January 25th. And Berkshire Chaffee Hospital has their winter EMS meeting that's coming up at the Springville Fire Department at 6 o'clock on Monday, January 5th, same night. Their topic is medical management of chemical agent casualties, a primer for EMS personnel. Then the last thing, just for general information for everyone, the 8th edition ITLS materials have been released, and those are now out, and instructors are updating. That's it.
All right, thank you very much. Anybody have any questions on the program agency reports before we move on? All right, moving along then, subcommittee reports. We're going to talk about collaborative protocols down a little bit, so there's no ALS protocol updates or discussion. Nothing I haven't heard from Alex, any QI issues, and there's no ad hoc level of care issues. I'll take that committee off the agenda.
Yeah, the only thing is you guys asked last month about, or 2 months ago, about looking at the minimum requirement things, and
Yeah.
we're happy to do that, but I think it needs to start with an evaluation of who's doing what before we figure out what we should take or leave.
Right, so the discussion we had at the last meeting was looking at, there's a lot of skills that are optional at the BLS level, and they've kind of always come in from the state as being additions and things, and at this point, saying what is the minimal standard in the region that we should be doing, or we should include for a BLS agency. I think certain things like glucometry, albuterol, epinephrine have all become commonplace, and so the decision was made that we should look into what, if anything, we should require all of our BLS agencies to do of those optional skills. Some things will always have to remain optional, but some things maybe we need to begin requiring. And the first step that Dr. Clemency had brought up is maybe we should look at what, of all of our BLS agencies, what is being done right now, what skills are optional, how many agencies are doing them, and maybe that gives us a starting point or a platform of what's required. So I'm not sure the easiest way to get that data, if that's from the program agencies, to look at who's credentialed and what. Would that be the easiest way?
I mean, we could tell you for the services.
Sure, yes,
Right, that's what we're looking
Yeah.
at for the service, not for providers, but saying how many BLS agencies do you have, and of those BLS agencies, just even a spreadsheet, who does glucometry, albuterol, everybody has to do epinephrine now, so I guess that's kind of the point. But any of those optional things, Narcan, things like that, is that something that we can get from the program agencies? All right, why don't we see if we guys can get that information together, and then I'll have you email it to Dr. Clemency. They'll email it to you?
Okay. MD word.
All right. Yes.
We had talked about QI, you mentioned that. One of the things as the program agencies, we have to participate in a regional QI program that's supposed to come from the WREMAC, and we have not been doing that. So I guess I'm bringing it to you. Do you have a regional QI program that you would like us to work on together so we can meet our deliverable?
I think this is a great job for the chairman of the QI committee, personally.
Alex, what you got?
So the answer is obviously we don't, and we probably should. So we'll reach out to Alex and then see if we can start putting something together.
Just to put this into time perspective,
Yeah.
we have to include the final report in our quarter that ends June 30th, which means we have to really be collecting data by, yeah, I mean realistically now.
Let me just say it.
So, Brian, if it's okay with you,
Yeah.
why don't we have a motion that you, me, and Alex will pick something working with the program agencies rather than waiting for the next REMAC meeting, because I think that'll really put them behind the 8 ball. So is it okay for the body to authorize Dr. Walters, Dr. Lundberg, and I to figure something out with the program agencies and that be the plan? I think that's probably the best way to do it, right?
Yep. That sounds reasonable to me. That was a motion
I
that
don't
you
know if
made?
you want to vote on it or if we just want to do it, whatever you think. Just do it.
I think, I don't honestly think that needs a motion. I think that's something
Let's
that we
do
can
it.
just do. I mean, it basically is becoming an ad hoc committee that we can just form and do. So
Sounds good.
we'll do it under as that. Any other concerns or discussion about QI?
I have something.
Sure.
This is going to involve both ECMC and us. I'm working with Denise, Don Turner, and Rob Orlowski. If you're familiar with the EPCR program, there's a pre-notification for STEMIs and stroke. So what we were planning on doing is having a pre-notification for traumas. That's a close call rule. We're talking about a close call rule for trauma on EPCR. So what would be nice is even if they don't fill it out initially, it will start getting ingrained in their brain to pre-notify, because it will be a close call rule. So if it comes in dispatch as a trauma, then it's going to be a close call rule to have that. And then it'll also have timestamp on it as well. So if they do put the correct time in there, we can extract that data. Or if it says, subtitle, 10 minutes prior to arrival, 5 minutes prior to arrival. So it will be a nice QI follow-up.
Do you guys have any comments from ECMC? I mean, I think the data is important. Obviously, it's required for accreditation, and if we start looking at that, that's fine. I think it becomes more difficult with our paper PCRs.
Yeah.
Data.
Yeah. We actually do this already.
Right.
We had this in place, what, three, 4
3
years
years
now, with very good outcomes.
Okay.
We're at our highest level activations. We're at 90% pre-notification, which is great. One of the things we're trending right now is not just the call, but a complete report, and I think that's maybe something we could maybe fine tune on this, just so that, the complete report really makes a determination of what level of activation we give our trauma team. So a simple thing like a Glasgow coma scale can make the difference between a full priority one or a consult, which is a big difference in response time. So we could probably fine tune it a little bit, but I think that we've had very good.
Yeah, I think that there's probably a lot of things that we can be looking at regionally as for QI programs to try to give us some better data or try to hardwire some responses in that. So
yeah, not even a data thing too, to have that close call rule for the pre-notification. I think for especially the high turnover rate for like basic life support and like the paid agencies, it's a constant reminder to pre-notify. So that will help.
you're talking about building that into their EPCR system.
That's correct.
Okay.
Yeah.
So I think I think we're getting into some operational things that maybe aren't quite REMAC issues.
Yeah.
I think they're great ideas. I think if we roll it into a QI, I think that they may help with some of those things, but I don't know that that's something that we directly oversee or focus on as the REMAC per se.
Okay.
All right. To go on to old business, there was discussion, we've been talking for a long time, probably a couple of years now, about the collaborative protocols. And we know that they kind of started out in the Albany region, involved a lot of the REMACs now, and there is trying to get all the regions, basically from Buffalo, from here, all the way across the state to Albany, and pretty much the entire state, other than Long Island and New York City, will be using the same protocols. These protocols already exist. There were a couple of regions that have kind of been holding out, and we've been having discussions for different reasons, and pretty much all the regions have agreed to adopt these. I think we're one of the last few that hasn't officially signed on to them yet. These protocols are being updated. They look similar to our REMAC protocols now, and that was intentional a couple of years ago, so the color, the format, everything looks the same. The goal is to have the next draft of the collaboratives out and approved or presented at the CMAC meeting in March, and then to get the other REMACs to all support and endorse that. So what was disseminated to the REMAC members is this MOU, and the collaborative group has basically come up with just a list of guidelines trying to say, here's how we're going to proceed going forward with the collaborative discussions, how we're going to vote on them, how we're going to approve them. And basically what it comes down to is that each region, every REMAC will be given one vote in the collaborative group. The decisions will be made by consensus, by simple majority. If you can appoint, it doesn't have to be the REMAC chairman, it could be, they use the term regional medical director, kind of synonymous with the REMAC chair, but also it doesn't have to be the REMAC chair, it could be the medical director and or his designee, and you can approve alternates as well. But basically to participate in the meetings, the discussions, to take information both from here to the collaborative group and back to the REMACs, to discuss these things, and then to eventually approve all the protocols and to adopt what's being used throughout the state. I think there's a lot of benefit to it. I think we all realize that we cannot spend the time that the protocols deserve to go through them as a region with all the physicians and to update these all the time. And I think that the emphasis really should be on trying to promote some type of statewide standard. The state doesn't have standard ALS protocols like other states do, and the collaborative effort would be the closest thing to that we will ever get. The group is asking for approval, or for every REMAC to vote and approve the MOU that you have in front of you and that has been disseminated previously. That basically gives all the things. Anyone is entitled to sit in on their meetings when they have them at the CMAC or on the conference calls, which will be go-to meetings. They will be recorded so anybody can watch and review, but only the REMAC will only get one vote for the person, whoever that is, that they designate as their voting member. I don't know if there's any questions or discussion.
So first of all, I think this is great. Do we get one vote or do we get three?
So the question is, for you guys on the phone, the question is, do we get one vote or do we get three? And it is, every REMAC gets one vote in the collaborative group.
Even though we're three.
But we're 3 REMACs in one. That's the difference.
I apologize, I did miss a little of this. So would CHS be a collaborative group?
No. This is the REMAC in general will be part of the collaborative group across the state with the other REMACs. So every region, we would be basically using the same protocols as every other region across the state except for New York City and Long Island. All right,
Okay.
so the question was, because we have 3 REMSCOs, should we have 3 votes versus 1 vote? I'll be honest, that was not brought up or discussed one way or the other. I think most of the REMACs are 1 REMSCO.
All, right? Except ours.
We're the only place in New York State where we have more than one region served by the same REMAC.
But the state recognizes each region, and we get a medical director from each region.
And they had to change public health law to ensure,
public health law for
because we got kind of screwed at the state council because we were only getting 1 vote because it followed the REMAC. They changed public health law, which was pure miracle when that happened when Dr. Cooley was our chair, but that was to ensure that we had adequate representation from each of the regions.
But you still only have 1 REMAC in a sense,
Right.
even though you
Yeah,
have
but-
3, you know.
Yeah, but the point is that so
Different
we're getting punished because we're trying to be more resourceful and better utilize the limited number of physician resources. So Melrems that has 2 counties that they're going to get the same vote as Western New York that has 8 in 3 regions, and that's. And I don't even know if Melrems is in it or not, but that's that's just an example. So this is with everything else that goes on, it just, especially with upstate New York and us being Western New York specifically, this is a very, very sore subject for me. And I really think I share your concerns. I don't even think I know I sent it to you, Dr. Walters. I don't know if I included you on that response, but I said the same thing. And I think we need to stick our heels in the mud on this one.
And I actually just didn't even know this was going to come up, but I asked Brian about it a few minutes ago, how much representation we had, because I think there should be someone from each of the areas that should have a vote.
I mean, the state recognizes us that way.
We can bring it up and we can discuss it. I don't
This
know
isn't
how
a
that.
state MOU, this is an MOU with.
This is an MOU with a
protocol.
collaborative group, which is, probably doesn't have a whole lot of legal bearing, I suppose, other than trying to say, here's our rules of order and here's how we want to proceed going forward. So we can bring it up and I can, pitch that to them. I guess you look at it one way. We are still 1 REMAC, right? And we have 1 set of protocols, and we're talking about we want to have adequate representation, but every REMAC, we still have 1 set of REMAC protocols like every other REMAC who's
because I disagree, because there are other areas where there are multiple separate REMACs that have gotten together and had the same protocols. So like in the Syracuse area, there were multiple standalone REMACs. So please, Scott and Donna, correct me if I'm wrong, anything else? There were multiple standalone REMACs that got together and had a single protocol together. They didn't lose their individual identities.
That's how the collaborative protocol
That's
started.
how the protocol started in Albany, and that's what they do around Syracuse.
So,
and other
I guess I don't know the answer to this, so I'm going to ask Scott maybe, or one of you know the answer, is if we look at the number of providers in this REMAC versus other REMACs, how do we compare?
We're the 2nd largest city in the state, so I would have to think that we're and we have a totally different, we'd have to be larger because we have, just in Erie County alone, we have 101 EMS codes in Erie County alone. You know, Melrem's can't be anywhere near that. Tim already speak to it, but Rochester would be, you know, comparable in size in terms of Monroe County to the city of Buffalo and whatnot. But the reason why this is so sensitive, I totally support the collaborative protocols, but I think our regional councils, and I can't speak for them, but our regional councils, I would think, would probably take exception to this too, because if the collaborative protocols in any way changes what we've been doing with specific levels of care in any dramatic way where providers or services or REMSCOs for specific regions in Western New York feel like they're having something taken away from them, I tend to think that they're going to get very vocal about this and then be concerned that we only have one voice in this, and yet maybe 2 extra votes would have helped to guide the protocol process to not take skills away or get things introduced that we may or may not want.
Or even more so, what if we have 3 unified votes that go against the collaborative, which sends a stronger voice that this doesn't serve what we're looking for. I'm for the collaboratives, but I agree. I just think we represent too many providers and too many different types of communities to have one voice coming out of here for something as important as our protocols.
But it would, just as a comment, it would seem to me that if the REMAC as a whole, you know, it became a situation where there was a controversy, and I mean, it doesn't say that because you sign on to the collaboratives doesn't mean you're going to be there forever. I mean, you can always go back to your own protocols.
But we don't want to get into the
technically,
game
right?
of
Well, you don't want to, but you're
coming and going.
Yeah, so I'll say this, being involved in the collaborative discussions, and Brian, you've been on the conference calls, and Joe's been involved, I think that they're very respectful of the variances in different regions and looking at the levels of care providers and not limiting skills and things like that. Especially when we start talking about CCs in different areas and things like that. I don't think there's any intention to limit or restrict things like that. Obviously, that's where we're at now. 10 years from now, who knows where we'll be or whatever down the road. So I understand that. I guess I don't want to, I think it's something that we should do and we need to do. We can go to them and say we would like 3 votes and see what happens. I don't want to do that if they're going to look at it and say, well, in the Albany area, we're one REMAC and one REMSCO, but we have more providers, or in some other region of the state, because then it's going to get into who's got more providers.
I would just say,
they don't.
I don't know if they do or not.
But I would just say, like, sign this 3 times. Say the REMAC, Big Lakes REMAC, sign it. Wyoming area REMAC, sign another form. And
But we're not a separate REMAC.
I don't know. So, and again, I agree with you. These are great guys. This is what I want to do. So I feel weird because I don't want to be torpedoing what I think is the right answer down the line, but I'm also trying to stand up for a region. And I think once we go in as one, we're never going to come out as 3.
Right.
So my next question is,
Yes.
if they make a protocol change, does it have to go through the same process as of individual hospitals being notified and whatnot that we have to do when we change our protocols right now? So do we have to send out return response and do all that jazz?
So every REMAC and REMSCO would then have to notify everybody the same way then?
And so I guess I don't understand what the purpose of that is, because even if they object, if we're still going along with them, it doesn't really matter.
So it doesn't to a sense. So if you still have to notify all the hospitals in the area, which then becomes all the hospitals, let's say, in the majority of the state.
Right.
That feedback would come to the REMSCOs or to the REMAC, then we would then discuss and take back to the collaborative group of this is the feedback we got when we're developing those protocols or changing them. It becomes a very big, cumbersome system, but just needs to be managed individually by the REMAC still.
I'm not aware of any protocol that's ever been defeated by a hospital and rejected.
Well, the
So
hospitals actually
sometimes
they cannot object. We have to take their comments and then decide if we want to accept
Technically,
them.
their representatives technically are sitting there.
Correct.
Right.
The vote is the representation of the hospital, so.
And then my final question is, what is the date you have in mind to jump on
Well,
the train?
so here's the deal, is that they're looking to come up with their next revision presented at the CMAC that comes up in March. Now, we don't have to get on board in March. We could adopt them in July, right? If we don't sign the MOU and are involved, then we're not going to be involved in the voting, I suppose, up until that point. Now, we still are involved in the conference calls and the discussions. I think that they still do take our input, although we may not technically get a vote. Although I would say that most of the decisions of the physicians around the state seem to be in line with one another, and there's not a whole lot of disagreement and things. So if that's a sticking point, I don't think that us not voting in March is going to, or by March is going to hold us up or not have our voices heard if we want to adopt the collaboratives afterwards for that point.
I don't know, what do other people think about this?
I think we need to throw that out there to them and find out what the group's thought is about having 3 votes before we can move forward. So I'd make a motion to table this discussion for today until you can go back to the group and come back to us with an answer of how they.
I would argue if they agreed to 3 votes, as we have 3 councils, then we would accept it.
So here's,
Would
I guess,
that change in the meantime? But if not, then it has to come back for us to discuss.
right. I think
But
that's a
we'd
fair
all accept
discussion.
it.
So is it fair to say that we all agree this is a good idea? We would like 3 votes in representation. We can take that to them and come back with whatever answer, whatever feedback we get from them, and circulate it by email among the voting REMAC members to make a decision and vote on it in between meetings, just in the interest of time.
I mean, the difficulty is, right, like, if they say no, we're still gonna do it.
Are we?
Are we?
Well, that's the question, is it a deal breaker or not?
Well, are we bound, if we sign this MOU, are we bound and committed to go with the collab?
Or get out altogether, Todd. You're either all in or you're all out.
Right, yeah, you can't.
So you can walk away from them at any time.
Right, so we're not bound. We can walk away and continue our protocols. We can't pick and choose and say, we're gonna use the Clever's protocols, but we're gonna have our own modification of it, or we're going to only take some of them and make up some of our own. It's a kind of an all or nothing thing. Now, that being said, there has been a lot of discussion on things that should not be included in collaboratives and should remain REMAC specific, regionally specific, like interfacility protocols and certain things like that. So not everything is going to be completely collaborative, but the majority of the 911 protocols will be in there.
I think it would be useful to sort of take a straw poll of who is 3 votes a deal breaker and who would, or I mean, I think we should figure out where we stand. I mean, I think we should have 3 votes, but to me, it's not worth not being in the collaborative program. So it's a terrible negotiation strategy. But
Yes.
thank you, Kevin.
And that answer may change based on what we hear from them, and maybe I would hate to straw poll and put some number in everybody's mind and then go to them. I would suggest that we go to them, that we present that we want, 3 votes, and see what they say, and then among the voting members, have a discussion via email and a vote at that point as to whether we do it. Just in the interest of time, so that we're not waiting 2 months, we're not waiting, because otherwise we're not going to be meeting before the next CMAC meeting, correct?
Yeah, the CMAC meeting is the 1st and 2nd of March.
But now, so don't we have to like notify or so if the climate protocols are going to be approved in March at the CMAC, right? You're saying, right?
They're planning on presenting them.
They're presenting discussion. So didn't we have to have like a first reading already, and then didn't we have to do this already? You know,
we don't have.
Because we're accepting another.
That's what I'm asking.
We can adopt them at any time. The next revision will be out, and then there they will sit, and then we would have to go through our process to implement them.
So how long do we have to start before we can do it? So I thought we had to like present them at one meeting,
No,
then
because-
do the mailings and all that other
It's a
stuff.
30-day comment period. is what we're
Right,
talking
all that
about.
stuff.
I didn't think we had to if we're accepting someone else's protocol. It's already been accepted by the state. It was
If
just a
they're-
letter
Yeah,
to the.
they're already approved.
If they're already approved by the state.
It's already used somewhere else, or
Right.
whatever.
So we can just jump on them at any time with, don't have to go to a state meeting, don't have to.
No, it has to go to state.
If they're approved, you can use them in your region.
And it's a letter.
But
It's
the
just a
process
letter of
administratively,
acknowledgement.
And we don't have to
Yeah.
notify our local region either, we just do it. So if they approve it in March at CMAC, the next day we can just vote and just.
I mean, I think from a technical standpoint, that, you know, if you're making a drastic change to the protocols, I think that the expectation would still be to notify all the hospitals and all that, and probably have a 30-day comment period. I don't know if that's, you know, this is sort of a unique situation, so I don't know the exact, you know, what Albany's going to say to that, but I would presume that they would want to do that. But the concept has always been that if there's a protocol that's approved in another region, it can automatically be approved into somebody else's protocols. So, you know.
We've actually already done it when we have taken changes that are already approved in other.
Right, so you don't have to go through that whole.
Put them in ours without
process.
Doesn't the normal process.
It's just a letter to CMAC saying that it's.
Yeah.
Dr. Tackett?
Just to step back for a minute and look at the, how we can validate this request for 3 representatives. We do, and we're the only REMAC that has 3 representatives at the CMAC.
Right.
That makes it unique in that there's no other REMAC that has that same feature. And the fact that we've had this, we have 3 votes on the CMAC,
Right.
I think really validates our.
Yeah, I think the
our
precedent
request.
has been set. I don't disagree.
Well, I guess you agree with Tackett's that if the state changes their law to have it so we have 3 votes, I find it really hard that this group would think that they would disagree with something the state had to change the law for.
So,
Not that we're trying to strong arm, but we're kind of saying, like, they changed
Do you have
public health law to give us equal representation. I think we would equally get that
Right.
through this group.
Ed, do you have data on number of providers in each region available?
I can get it, I don't
Can
have.
you get that?
Yeah.
Because I think that would be good too, because if we find out that we have an overwhelming majority of providers compared to other regions, then I think that that's one more.
You can even just do it by population. I mean, just because population is probably just a pretty good rough and dirty proxy.
Well, you have the
I bet that Erie
numbers right
County
in front
has
of
more.
us.
Population density.
Yeah, I bet that Erie, Wyoming County alone has more than probably every other
Can you
upstate
look into
region.
that and see if you have some like basic numbers?
Yeah, I can get you some.
It's not too difficult to get. I think the other discussion, just to be aware, is that there are gonna be some things that are going to, there's gonna be some formulary changes and things like that that we all have to accept. And I think that this is actually going to push us more into being in line with some national trends and regional trends and even what's being used across the state. I mean, I think a lot of people have gone to, say, Versed and fentanyl as being the standard controlled substances that they carry. And we still have people that are using Valium and morphine and things. So some of those things are going to become, we're going to have a standardized protocol or a standardized formulary. And I think that actually will move us forward as a region and actually help kind of push the standard a little bit. But those are just those things that we're going to have to consider to accept when we do this. It's not going to be, we'll get a voice in discussions, and anybody can voice their opinions in discussions. We'll get the votes, whether it's 1 or it's 3 votes in the collaboratives, but it's not, where every person gets to add their own little tweak or spin on things. It's what's best for the group and what's best across the state, just so I think everybody's aware of that. I think everybody understands that, but just so that's all disclosed up front. So I will reach out to them, and then I will get the answers based on about both the vote and the 30-day comment periods and things like that. Any other discussion or questions that?
No, I just think we need to phrase it, we're not asking for 3 for our REMAC, we're asking for
A
1
vote
for
for each
each of our
REMSCO.
3 REMSCOs.
Correct.
Well, do we want to vote that if the answer is yes to
Automatically,
to 3,
Sorry,
then
accept it.
we vote yes now?
I think it's great.
And if-
Brian?
You should be covered on that. The voting member is the regional medical director or physician approved designee. Regional medical directors are appointed to CMAC by the councils. There are 3 councils here, that's 3 votes.
But there might be
Sorry,
conflicted
Robert.
verbiage in there about.
The
for
CMAC
REMAC.
representative is not, Brian, I don't think the CMAC representative is automatically the regional medical director, though.
I would assume that to be the case based on the way they wrote this document.
Not CMAC representative.
It's my understanding that the REMAC chairman, the regional medical director, and the CMAC representative can theoretically all be 3 people or all be the same person.
Sure. I don't disagree.
You know what I mean? But I'm up there for any argument that proves the point.
Yeah.
So I think Kevin's got a great point. So I'd like to second Dr. McGee's motion. That if they're agreeable, that, or Kevin's idea was
You can have
sort of restated, right, that, I thought, did you say it? I thought you said.
He said it last.
Oh, I'm sorry.
You want me to restate it?
I thought it was much better when I thought it was McGee's idea.
Yeah. All right, let's put it.
He's
put it
never
down
said
as
that.
McGee's
He's
idea.
never said that.
So the motion is, if the collaborative group is agreeable, or will clarify that we have 3 votes, 1 for each state representative that we have in our region, then then our vote is to support that. If not, we will have to go back to a meeting discussion.
Okay. So for
And
those
get
of
the
you
regional, and get the regional
on the
council.
phone, Dr. Lynch has made a motion that if we go to the collaborative group and they are willing to give us 1 vote for each REMSCO, his motion is that we go
Sign the
to
MOU.
sign the MOU for the collaborative agreement. If they do not agree to give us one vote for each REMSCO, then we'll bring that back to for more discussion, and in the interest of time between meetings, we'll circulate that discussion between voting REMAC members between meetings.
Sounds fine by me.
Is there any discussion on that before we vote?
One quick one.
Yes.
If they do give you the three, you need to have a process for identifying who the three votes are going to be. Will it default to the CMAC representative for each region, or will it default to a chairman's appointed three
So
votes?
that's something that we're going to have to come up as a REMAC, but it's not going to be written into their MOU, but that's something we're going to have a policy.
But it will be a factor before our next meeting, because if this is executed before our next meeting and the protocols are voted in March 1st and 2nd, it'll be an issue before that point.
Okay, so continuing on with my motion, the representatives would be named by the REMAC chair.
Okay, wait, so I think these are two separate, let's just vote on the first motion first,
Yes.
and then we can come up with the second
One
one and
per
discuss the second
council.
one. So the motion that we're voting on right now is that if the collaborative group gives us one vote for each REMSCO, or 3 votes for our REMAC, that we adopt the collaborative MOU and participate in the collaborative protocols. All in favor?
Aye. Aye.
Any opposed? Any abstentions? All right, that passes. Give us a second. All right. All right, Josh, your discussion then as far as representatives from each region to the collaborative group, if they give us 3 votes, was what?
I think Dr. McGee had something else to say.
Well, I don't know, I think it would need to come back to a little discussion, because I personally think the councils, they pick their own CMAC members, or representatives, I think they pick their own collaborative protocol members, but that may be less efficient. So I don't know that this is ready, we're ready for a motion yet. Let's
Okay.
see if we're getting what we need that, and then we worry about it later.
Right, so I guess in the meantime, the discussion is who should be those, if we do get 3 votes, who should those 3 people be, and what's the process for that? And I guess they should be appointed by the REMSCOs, perhaps, or should it automatically be
That'd be my gut.
there's the CMAC chair from the REMSCO?
They disagree.
I disagree. I think the obvious answer is probably the CMAC rep, because they're there at the meetings where the discussions are had.
I think that would make the most
Or we
sense.
give the-
I'd be fine with that, that's still picked by the,
Or
that's
we
still
give
the
them-
council picks their own rep, so.
Well,
So,
I think that makes the most sense, however, I think the REMSCOs ultimately are the towering body here. I think the chairman of each REMSCO should make that appointment. And most likely, logically, it would be that CMAC rep. But
Yeah.
I still think the power needs to lie with the chair of the REMSCO.
Todd, I agree with you about giving the REMSCOs the power, but I think that if we start making this too cumbersome, we're going to make it more complicated than it needs to be, and we're going to be paralyzed by inefficiency. I would say, I guess what I would ask is that, I'll put out there and I would ask for everybody to take back to their regional councils to discuss at the REMSCO meetings, is that if we have a physician that is appointed by the REMSCO to sit on this CMAC, we've already appointed a physician from each REMSCO to represent them, do they agree that that person that's their CMAC representative will be their representative for the collaborative discussions? And again, that would seem to make the most sense, because they've, 1, already been appointed by the REMSCO, and 2, that physician is going to be at those meetings when those discussions take place in Albany at the CMAC regularly. So I'll ask that that be brought up for discussion at the REMSCO meetings, and then if there's any further discussion or disagreements after the REMSCOs, then we can discuss it further at the next meeting.
Doesn't it need to be a motion that we all vote on, if that's going to be the process?
We don't know that it is.
Hey, Brian.
Yes, Joe.
So, I'm going to agree with you, not to give myself more work, but already being at the CMAC meeting, we're already knee deep into this. So, I mean, having that represent the part of it makes a lot of sense. I disagree that this should go back to the regional councils, because ALS protocols are a nature of the REMAC, not the councils. And third, while we were doing all this, I texted Mike Bailey, and he said, to make it easy and clean, one REMAC, 1 vote. Albany has 5 counties and 1 vote, and Milrose has 2 counties, and several other have 3 or 4 counties, and they still get 1 vote.
No, that is not true. That might be true for counties, but that is a classified region by New York State. New York State clustered 5 counties together and called it one region for a specific purpose. Melrems has 2 counties. Wyoming area has 2. Southwestern has 3. The New York State defines who the regions are, and then it's council for REMAC. We are the only location in New York State where there's more than one region, not counties. There's more than one region that is serviced by a singular REMAC. So that's what the concern is. It's not about counties. What Dr. Daly is saying is absolutely true, but it's by region, not by individual counties, and that's what the concern is for this.
To me, it just appears that the collaborative agreement does say clearly that it's one vote for one REMAC.
It clearly does.
So it does. So
It
I
clearly
don't.
does. But it's the
So
only time.
unless you're going to divide it and say, okay, now we got 3 REMACs, which I don't think anybody wants currently, and I don't think that we would encourage that. I don't know if it's that big of an issue myself, but that's just my opinion.
Any other discussion?
That would be an unfortunate side effect of, it's like being like,
I
fine,
hate
we'll
to
go
see
to 3
that happen.
REMACs,
Yeah.
we got 3 votes. I mean, that's.
Yeah, we wouldn't have enough for a quorum if we had 3.
we can make it
One
close.
region would.
So we do not have a regional medical director,
That term, I think, is what they use for, to mean,
but I'm saying we don't have anyone defined because the
Right.
way our REMAC, or because our REMAC is so big.
right.
So,
I think that's a semantic issue where it says regional medical director, they include that to be REMAC chair or REMAC regional medical director, so. The point is that you get a designee or you get someone appointed to.
No, I know, I just want to make sure we
So,
don't.
so I guess given
use that
Dr.
title.
Bart's communication with Dr. Daly, do we feel differently about this or how do we want to proceed at this point?
I think that there needs to be a discussion about it. So I think you should reach out to him and give the background on our
Alright.
discussion.
So then,
How often are we not on the same page with these things? I mean, to be perfectly honest, we spent a lot of time talking about protocols and what we're gonna do with them. Even if we have 3 votes for our own protocol subcommittee, how often do we disagree and not still be approving? So, I mean, being a matter of what this is, you can part the protocol discussions and the collaborative group, they're open to everybody. And the altruism is on the side of making the protocol better. If we gain something like 18 or 19 additions to our current protocol, we lose nothing. So the idea that we have 1 vote or 3 votes here, how many times would we have suspension amongst our 3 votes that would actually make a difference at all? I mean, I understand the power of the vote, but as we discuss losing this, it sounds like around the table, people have fear of losing our representation. And I really just don't think, knowing that group, I really just don't think that that's something we need to be concerned about. I understand about the 3 votes, but I think we're wasting time talking about this stuff, because the protocol for the collaborative is a good move for all of us.
and I agree, I mean, sitting with Joe, I can tell you that everyone's voice is heard, there's good discussion about what we decide, and usually someone presents a good argument based by evidence as to why we're going to move one way or the other, so.
Until someone picks a fight and doesn't like somebody.
There's not going to be a problem until there's a problem.
Yeah.
That's what I'm
You know,
saying.
and
That's my point.
But that's
There
the
won't
whole
be a
point
problem
in this,
until-
is to protect there being a problem.
All right,
So it might seem trivial to them and a logistical thing to them, but I think we've worked very hard for a long time hashing out 8 counties and 3 regions when we do our protocols, that I think to suddenly take away the feeling of being all inclusive would do a disservice to our region. That's all.
So,
I still think we need to make an official request to the body of the collaborative protocols that I think we do feel strongly about this, and let's get an official ruling from the group. And
I will go to the collaborative group and present our argument and for discussion rather than text discussion between Dr. Daly and Dr. Bart, and then we'll report back and go from there and see if we can try to get those votes for ourselves. Other than that, any other discussion about the collaboratives right now?
What date do we have in mind
What date for?
to be on the collaborative protocol?
To adopt these?
Yep.
I think I guess that's probably a discussion for that comes out of after all these other
Well, I
discussions
mean, I
about
think
representation and things like
is
that.
the goal March, if we can get the representation worked out? I think that could be a bit early.
You know, I think that I'm gonna reach out to them too, because we've talked about, even if they get approved at the March meeting, there has to be, is there gonna be a big overhaul and a big change for a lot of regions? And there was discussion about doing one kind of protocol update or protocol in service that everybody could use across the area, which is the other benefit of the collaborative group. And I don't see that that's going to happen, even if they were approved by the CMAC in March. I don't see that that protocol update is going to be put in place before then. So why don't I try and find out from Dr. Daly what the time frame is for that as well?
I think a realistic goal for rollout is the summer.
Say summer? I don't disagree.
If they're approved in March, we work out the representation, and we either use their educational rollouts or we create our own. I think that's a couple of months of work.
Yeah, that sounds reasonable. All right, moving on. I'm going to skip this versus EMS, we'll talk about it later. The only other thing under old business, which is not on the agenda, is CPAP. Obviously, that's been approved by the state to roll out. We did have a educational PowerPoint that Dr. Clemency and group worked on very hard that was approved by the state and is ready to be rolled out. The only other discussion, which we've talked about before, is from the program agencies, that we come up with a packet or a standardized implementation thing like for NARC before for CPAP yet or not?
We're gonna close it up tomorrow. The problem was I didn't have the PowerPoint, and
Okay.
I guess the other thing I just wanted to clarify is who's allowed to teach this? Are we?
New York State said it had to be a level 3 or level 4 CIC, or you could use a medical director for the service, but it has to be a level 3 or a level 4 CIC.
Is that what the state says?
Yeah.
So not a CLI?
Correct. It cannot be a CLI. It has to be a CIC. Okay, because it's didactic. The skill piece of it is, probably the manufacturer can commit to do it, but it's, the didactic piece of it has to be a level 3 or level 4 CIC.
Can we make this notification only?
Yes.
Great.
Similar to NARC.
Great.
Right?
Yeah. What does that have to do with the instructor?
What's up?
It doesn't.
Oh, okay.
All
Can
right.
it be a REMAC preceptor as well, what they did with the, don't know?
No, not if the state policy requires a CIC, then it requires a CIC. And we can't vote to change that. All right, new business. I'm not going to ask for a vice chair nomination right now, but as my term is less than a year from coming to an end, I would encourage other people sitting at the table to my left to discuss that, or any other physicians in the crowd. So if anyone is interested, you can let me know. I won't put you on the spot now, but we should start thinking about that. There is looks like, is it BCMC or is it BGMC? Okay, I'm sorry. So Buffalo General is changing the REMAC chair from Dr. Borton to Dr. McGee as the alternate. Do we need to vote on that, or is that just a notification? Just a notification. Thank you. There's a couple other notifications here very quickly. Erie County Emergency Services has submitted a notification of intent to become an ALSFR as part of their municipal CON. Dr. Bart, do you want to make any other comments about that at this time or not?
Why not feed the dog? That's the question.
About Erie County Emergency Services intent to become an ALSFR?
I don't have anything to talk.
Okay. I think that's more of just a FYI for people. There was some discussion that was put on the agenda about transfusion, the new transfusion regulations and that. And there was a question that was raised about whether these should be REMAC protocols, if they need to be REMAC protocols or not. This was discussed as I go back and I look at some of my CMAC notes. It was brought up and discussed there, and I know Ron Hassan had reached out to Lee Burns for some clarification as well. And the discussion at the CMAC was that the requirements require any agency that's going to be adopting blood transfusion that they have to integrate with their hospital blood bank, and all the blood banks have slightly different protocols in that you're going to have to adopt as the EMS agency. So it really wouldn't be feasible to have a standard REMAC protocol because every hospital is going to have a slight difference, although they say basically the same thing. there's going to be a little difference between every hospital's transfusion protocol and guidelines. So I don't think that that's a WREMAC protocol that needs to be developed. There was discussion about whether transfusion reactions needs to be a collaborative protocol to that extent, even just of the reactions. But again, every blood bank has its own protocol for treating those transfusion reactions, although are pretty standardized. There are some little differences, and so we felt that that was not something that was really a function of the collaborative group either. I don't know, Ron, if you have any other feedback or input on that, or any other questions that you want to bring up after your discussion with Lee.
Sure, and I did receive follow-up emails from her today. I don't know if you got a chance to read the email, but here's the question I posed, because this was based, Phil and I had a meeting with our blood bank and lab personnel at WCA Hospital yesterday, and apparently with the promulgation of blood regulations allowing for these ambulance or ambulance transfusion services, they changed some of the other blood regs, and we received some disturbing news today. But I did ask, does there need to be a WREMAC protocol, because it's mentioned in the educational documents that the state provided, and she said the answer is not really. Protocols are set by a few things: standard practice, sending physicians' orders, education programs. So the WREMAC protocols of significance in transfusions are anaphylaxis, allergic reaction protocols for transfusion reactions. She does say, however, WREMAC should have some say in the educational programs in their regions, as well as involvement in quality assurance as appropriate. The other thing, I hesitate to bring it up here because this is for Lee, and I'm hoping it will change. But as, I don't know if you folks in Buffalo aware of this, but we send a lot of people that have blood running, but it has to go with an RN. The regulations, the way they're worded now, because of the other changes, basically say this patient can only have blood running if that hospital's RN goes with the patient, or an ambulance transfusion unit service that that hospital has an agreement with takes that patient. So currently you have people like Starflight and Mercy Flight with nurses on board that are picking patients up in these small community hospitals, taking them to Buffalo or wherever, and those hospitals are starting blood, and these units can now continue that. Or the way the regulations are worded now, that's a no-no, unless they're an ambulance transfusion unit or service.
So you're saying that you would have to, as, let's say, Mercy Flight or Starflight, you would have to have an agreement with each hospital that you transfer a patient out of?
Correct. You would have to first become an ambulance transfusion service, which is you go through all the rigmarole with the first hospital that you're cooperating with. And then subsequent hospitals, you would just then be submitting your agreements to the state to be approved to be an APS, they call it, for that service. And you would do additional training based on whatever tubing they use, or different, slightly different transfusion paperwork, etc. But the problem we have is, if the state says we're going to enforce this now, is a hospital, right now, there are no APSs. That means a hospital sending somebody out with blood running has to send their RN. And that's a problem. So we're hoping that during this transition period, I did not ask Lee this because these are one of those questions you don't ask them, so cover your ears. Is that we can continue as is with using Mercy Flight and Starflight nurses to transport these people, because otherwise these hospitals cannot afford to send a nurse out on a 2-hour, 3-hour, 4-hour trip to Buffalo.
Correct.
So that's where we're at with that. There were some other questions we asked which aren't appropriate for this forum,
but I guess the discussion is that from the WREMAC, there isn't really anything that we need to do or even can do as far as protocol development for transfusions or anything. It becomes the aid between the agency and the hospital.
Right. There is a notification to the WREMAC when you submit to become one of these entities.
Right, but that's a simple notification rather than anything that we have to approve or develop.
Correct.
And just for this region, we've received one so far. I know Trans Am has applied, and you guys have been notified about that. They submitted that to our regional office. We submitted it to our central office. They sent it over to the blood transfusion people, and we're waiting for approval for the one that we've received so far. So just as far as the process goes.
Okay. All right, moving on then, the only other item is was an item about Mercy EMS operating in the village of Springville, and I've received some correspondence that I'm going to read. I think that this is more just of a notification that they'll be operating. Is it a contract with the municipal CON in Springville now?
Yes.
Okay. So the email, as discussed, Mercy EMS was previously approved as an ALS ambulance agency by the REMAC in the summer of 2009, when we received our Genesee County CON. As of January 7th, 2016, Mercy EMS was contracted by the Village of Springville to operate via their municipal CON. I have been asked to get basically an acknowledgement of the REMAC that the operator, Mercy EMS, is already a REMAC-approved agency at the ALS level, and the REMAC is aware that the operator, Mercy EMS, will be the operator in the Village of Springville in Erie County. So that is more of a notification. I don't know if there's any, we don't need a vote because we've already approved them as an agency, but more of just acknowledgement and FYI. Scott?
It's the same thing actually for Erie County's Uni-CON request. It's notification because in the Uni-CONs, it's an expedited CON process. Traditional CONs, you have to have essentially a letter of, I won't call it endorsement, but a letter from the REMAC that says that they're aware of the intent and that they will be, that their service will be eligible to function within the region. And so Erie County is probably going to be looking for the same thing for theirs, which is why that I'm sure is on the agenda here. So it's just letters from the REMAC stating that they're aware of the service's intent and that they will be eligible to service the region under the REMAC at that level.
Very good. And then the last is, I think we'll entertain a motion to approve en masse, like we always do, the medical director changes which are listed there, add notifications, level of care change for Gary and Maple Springs, notifications of naloxone, notifications for check and inject, and for chemistry approval, EPCR approvals. I have a motion to accept all of those as listed. Josette and Dr. Lynch. All in favor?
Aye.
Any opposed? Any abstentions? That being said, before we adjourn, Ed?
I'm sorry, just got one thing. There's a, the Western New York Pediatric Disaster, it's sort of a core group. The meeting actually is going on in the other room. They will be coming potentially to the REMAC to, you know, they're developing their stratification and different levels of what hospitals can do what as far as pediatric MCI type stuff. And one of the things that they brought up in the meeting today was communication about in the event that there's an MCI and they're specifically addressing a pediatric type situation, which hopefully is rare and something we won't have to deal with, but they want to look at the possibility of alternative destinations for lower acuity type patients. I just brought up the fact that in our protocols, you know, REMAC protocols indicate EMS can only transport to Article 28 facilities, and it's just something that's coming down the line. I told them that I would mention it. They're looking at,
they wanted to transport to.
Yeah, there's a few pediatric groups that could take non-acute patients to, you know, in a situation in whether it's a.
There's two of them.
Oh.
Yeah, there's two of them, and
And we can't do that because it's against the state.
It's against REMAC protocol. The REMAC has a policy that indicates that EMS can only transport to Article 28 facilities. There is no nothing prohibiting transport to alternative destinations if things are approved, and certainly there's insurance liabilities and all those kinds of things. You know, people won't get paid, but your designation designates to Article 28 facilities. So they're going to be coming forward with potentially a request to, in any extreme circumstance, whether it's a public health emergency and the EDs are overwhelmed from the pediatric side, to potentially, you know, this is probably a long ways away, but they asked me to bring it up at your meeting, so I said that I would. So thank you.
All right. Well, I guess we'll wait to hear from them, and then we can discuss it at the next meeting. Any other issues before we adjourn? No? All right. Then I think we're done. Thank you very much, everyone.
Thank you.